So this would be consistent as a biopsy-proven high-grade squamous intraepithelial lesion. So algorithm then for management of this patient comes down to a plan for managing high-grade lesions that could be divided into patients where the colposcopy is adequate or in patients where the colposcopy examination is not adequate. So if it's adequate, then we could do diagnostic excisional procedure. So this would mean a loop excision. One could do cone biopsies. However, cone biopsies generally require a trip to the operating room, require anesthetic, it's a higher cost. So most of the time we're doing office-based loop excision with just a local anesthetic. An alternative approach, though, would be ablation. We could do cryotherapy to freeze the lesion. As long as the lesion is small and as long as the lesion is completely seen, as long as our cryoprobe can cover it, then this becomes an equivalent therapy in terms of effectiveness of treatment. Once that treatment is done, there have been in the past arguments about how often we should do follow-up. As we've learned more about co-testing, it's clear from the COT-key data that I showed you from the Kaiser Hospital on the first day of our meeting, that if we have negative co-tests, the chance of a woman developing a cancer from that point forward is very low. So this means we can develop a strategy for a guideline to be very uniform about how we follow up, and that it would be less intrusive, less trips back for evaluation than old guidelines previously recommended. So the current recommendation then would be to do co-testing at 12 and 24 months. Now that's still more often than routine screening, but it's a lot less than old guidelines where we were potentially doing cytology every 6 months for 2 years. So we're trying to reduce the number of trips of our patient into the office for evaluation. If both of these tests remain negative, then she could have a 3-year follow-up and then return to routine screening. So our hope is to effectively remove that lesion and then get her back to routine screening as soon as is safely possible, and reducing the number of trips back for cytology. There is no recommendation in this algorithm for doing follow-up colposcopy. This helps to reduce cost, it reduces intrusiveness of biopsies, it reduces the morbidity. This would be a similar scenario, a patient where the Pap test showed a high-grade squamous intraepithelial lesion. However, this time when we look, we cannot see the squamo-columnar junction. The lesion extends into the endocervical canal, and so now we need to have a different management plan. If we come to our algorithm again, our various options include doing the colposcopy,